Go live.
Okay. Good afternoon, doctors. Hi, Dr. Prashant. Welcome you to this webinar on influenza and its prevention organized by Hitro. Doctors, as you know, Hitro Healthcare is an innovative pharmaceutical company with 30 years of excellence and 300 plus products in portfolio. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have 36 state-of-art manufacturing facilities. We have presence in 126 plus countries, and we have got Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. Hitro Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs. We reach out to customers across India, and we have a wide product range encompassing multiple specialties. Pioneering in quality and innovation, we have the distinction of bringing 4 biosimilar products to market within 5 years of launch. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic area, Hetero Healthcare introduced 3 antivirals, oseltamivir, favipiravir, and remdesivir for patient benefit, for which we received an award of Pharma Excellence in August 2020 for COVID drugs. Today for this webinar, we have got eminent speakers Dr. Ketan Shah and Dr. Ravindra Chopra. Dr. Ravindra Chopra is MBBS MD Pediatrics. Sir is Chief Pediatrician and Director, Muskan Children's Hospital, Surat. Dr. Ketan Shah is MD DCH. President is President Surat Pediatric Association. National Trainer ATM, PSPP, ASK, IAP, CPIDC. How do I investigate? Rational Antibiotic Practice, National TB Module, Rapid Module. Dr. Shah has been National Secretary, Pediatric Rheumatology Chapter 2005 and 6, Organizing Chairperson, National Rheumatology Meet 2006, EC Member, Gujarat Pediatric Association 2014 and 19, and EC Member, ID Chapter 2013. Welcome, Dr. Shah. Welcome, Dr. Chopra. And over the session to you for your deliberations. Thank you, sir. I'll stop sharing this.
Good afternoon, everybody. Thank you, Dr. Prashant, Samriddhi, and the IT champion, Mr. Jayant. Welcome, Dr. Ravi. Ravi has been very close friend of mine and is very expert in the respiratory and infectious disease management. Today, we'll be discussing something about the influenza disease, oseltamivir, and the clinical scenarios where you get the patient and how to manage this. We'll be having a bidirectional talk. I'll be sharing something, Dr. Ravi will be sharing something, we'll have a question answer, we'll have a case scenarios also. The healthcare challenges in monsoon and their diagnosis would be our point of discussion. Influenza, or classically called as a flu, and its complication. Clinical evidence of oseltamivir, and guidelines recommendation for empirical use of oseltamivir. In the monsoon, we get shardi khasi or cold cough. Every mother, every adult would tell कि बारिश हुआ और सर्दी खांसी शुरू हो गई. If it is only a shardi khasi, minor cold cough, we can ignore it. But if it is more coughing, more fever, breathing difficulty, then we are worried for severe acute respiratory illness, COVID-19 and H1N1 also. And obviously, influenza-like illness. So in this situation, we have to be very careful for diagnosis. Dr. Ravi, I'm going to ask you these 3 questions. What we know about influenza in India, in which season, and what is the correct time to vaccinate? Over to you, Dr. Ravi.
Thank you, Dr. Ketan. Thank you, Hetero team, for inviting me this interesting topic. Coming to our talk today, so influenza, we broadly say as ILI, influenza-like illness, when a patient present to us in a OPD practice, so we label it as ILI initially. So ILI basically is any febrile illness with sudden onset of cough, sore throat, and fever which is more than 100.4. There are associated sign and symptom along with cough and cold, maybe vomiting, myalgia, maybe letharginess, dehydration. So these are the associated symptoms. Generally, uh, in our OPD, we see if we see 100 cases of ARI, almost about 10% of them would be probably in the category of influenza-like illness. In our country, basically our country falls in that kind of area where we have northern hemisphere as well as southern hemisphere represented in our country. So we get influenza almost all around in different part of our country. The winter season influenza or winter flu is generally seen in the northern hemisphere, which generally peaks at around January to March. And in our part, in the southern hemisphere, generally the influenza is a post-monsoon flu. Generally during monsoon, generally August to October. And hence the vaccination is planned in such a way that uh, the data are collected according to the particular season. And we generally vaccinate in our part of the world, generally vaccinate in the early part of pre-monsoon season, like April to June or July. Whereas in the winter flu, we vaccinate the kids generally before winter season begins, that is around September to December. So that is the science behind vaccination, because we want to cover the peaks of influenza, which happens respectively in different seasons. Over to Dr. Ketan.
Yes, Dr. Ravi, thank you. You rightly mentioned about the incidence of influenza in India. We'll be seeing a few graphs which is narrating how common is influenza in India. This graph is taken from the Purple Book, which is the Indian Academy of Pediatrics vaccination book. It is from page number 324. As depicted in the graph, January to April is the peak, usually February, March. And we all know that during 2009 epidemic, 2019 epidemic, we had so many cases of H1N1 in February, March. May, June, bit silent. And again, July, August, September, and October. So these are the peak seasons of influenza in India. It is now November month, so we have a very less OPD after Diwali. But during July, August, majority of the patient were of respiratory tract infection. These are the statistical figures of 2017. The number of episodes were more than 1396630, and the death were 26,000. These are the figures which indicates that we had a global burden of the disease, especially in India also. These are the number of cases which were noted on November 2022. In 2017, we had 38,811 cases and 2270 deaths. And in 22, 12,881 cases and 399 deaths. These 22 data is only up to March. So looking to the scenario, we have a confirmed evidence that India has a lot many cases of influenza. 5 to 10% of all ARI are due to influenza in India. 10 out of 100 children per year suffer from influenza. There were two different studies, 180 and 178 per 1,000 children per year below 1 to 2 years were noted to have influenza-like illness. Influenza-associated respiratory tract infection, we have a 33 to 44 per 1,000 children per year incidence. And in 2009 pandemic, almost 22.8% were positive for influenza. In 2015, up to March, the record were 30,766 positive and 1809 died. So it's a huge burden. The whole slide indicate that India has a good number of respiratory and out of all respiratory, huge burden is of influenza or flu-like disease. And rightly, Dr. Ravi had said that in northern India we get a peak in Jan and March, central India July to September, and southern India September to November. Winter and monsoon obviously are the peak season, and pattern of circulating strain varies from year to year, which is a global phenomenon, not only pertaining to India. This is an overview of influenza in India. In 2019, almost 20,000 cases were reported, and 1218 was the number of death due to influenza. Dr. Ravi, can you highlight something about this study? Over to you.
Yeah, thank you, Dr. Kiran. So this study is an interesting study just to, show the incidence of influenza and peaks of the influenza. So this was a study done for the dynamics of occurrence of influenza in relation to the seasonal variation. This study was conducted in Chennai, Tamil Nadu, and it was a 7-year cumulative study. The study was done by Department of Virology of King Institute of Preventive Medical and Research Center. Out of there was 36,617 70 specimens which were subjected for the influenza analysis, and this was throughout the duration of study years, that is 7 years. And this study was a hallmark to show that influenza positivity started with the onset of monsoon and peaks during the post-monsoon season. So, as we already discussed, this kind of a thing that in our day-to-day practice also, we in our southern part of India see that there is a peak just during the monsoon and post-monsoon time, and the things might be different in northern region. So, this study highlights the seasonal changes in the influenza incidence. Dr. Ketan.
Thank you, Dr. Ravi. So let's know something about influenza. It is the most common infectious disease caused by influenza virus. It is highly contagious, airborne disease, occurs in seasonal epidemics, and manifests as an acute febrile illness. It can be mild to severe illness, and serious outcome of flu infection can result in hospitalization and even the death also. There are three types of influenza virus, A, B, and C. A and B are very notorious to cause epidemic, maybe endemicity also. C seems to be a little bit minor variety, but sometimes it can cause epidemic. The currently circulating in humans are subtype A, H1N1, classically called as a swine flu, and H3N2 strain. Dr. Ravi, when we discuss about influenza, always a word comes like drift and shift. Can you explain us what is drift and shift?
Yeah, sure. So, to understand shift and drift, we need to understand the viral structure first. So, influenza is a RNA virus, and the classification of this virus is according to its nucleoprotein and M capsid protein. M capsid protein is found in type A virus only. Actually, there are four kinds of viruses A, B, and C, which are found in human, and D is in the cattle only. So, according to these nucleoprotein, they have been decided. And there are subtypes depending on the neuraminidase and heme agglutination. So that's why we label them as like H1N1. So this kind of a presentation is basically for A type of virus. So in drift mutation, so we have a genetic mutation within the genome of the virus. So this is a transient small mutation. Definitely, it does not give cross protection to the previous virus. But this is a minor mutation. The parent virus remains the same. Whereas a shift mutation is a whole reassortment of the viral material. So it is entirely a new virus. And generally, this kind of a shift and drift mainly seen in the A virus, which is unstable virus. B virus is a generally stable virus. There are hardly any variation. Only two lineages are there, like Victoria and Yamagata. and C is an entirely stable virus. So because of instability of the viruses, it has implications in their seasonality. So A virus, since being having multiple drift and shift mutation, is responsible mainly for the pandemics because the immunity or cross immunity is not there. And seasonality is also more with A virus because there are multiple drift mutations in this virus. So A virus is notorious for pandemic, epidemic, sporadic, all kind of cases, whereas B is generally a stable virus, minor mutation, little bit of drift mutation, and C is entirely a stable virus. That's how the importance of repeated vaccination. We take every year vaccination. Why? Because the virus is changing its nature every time, and it is almost always a new vaccine rather than a booster dose. Over to you, Dr. Ketan.
Thank you, Dr. Ravi. This is the basics of influenza virus. We need to explain the parents and the patient also that the virus strain changes. So every year you'll have to take one dose, which gives you a good protection. The flu can spread at the distance of 6 feet. We need to follow the all COVID protocol to prevent the spread of a flu virus. It usually spread by droplet, and when a person cough, sneeze or talk, he can spread the disease. These droplet can land in the mouth or noses of the people who are nearby or possibly be inhaled into the lungs. People should stay away from the affected person and stay home if you are sick. It is also important to have hand wash hygiene, and most healthy adults may be able to infect other people beginning from day one, even before the symptoms develop, and up to 5 to 7 days after becoming the sick. And children can pass the virus more than 7 days, longer than 7 days once they are cured. So these indicate highly infectious nature of influenza virus. These are the clinical symptomatology of influenza-like illness, H1N1, severe acute respiratory infection, and COVID-19. This table may be a bit more of a theory. Practically, any respiratory distress falls into these 3-4 category. If you have a COVID, breathlessness is more, loss of smell and loss of taste is more common with COVID. However, even with H1N1, you may get loss of smell and loss of taste. Diarrhea is more common with COVID-19. Clinically difficult to differentiate, but any patient coming to you with a breathlessness, just think of H1N1, severe acute respiratory infection, and COVID-19. There are few more other viruses which can come up with the breathlessness, fever, myalgia, cough, loss of energy, sore throat. But in a given season, first differential would be H1N1 and the COVID-19. Dr. Ravi, can you highlight what is the spectrum of the disease so far so H1N1 or influenza is concerned? Over to you.
Yeah. So if we talk about clinical spectrum of the disease, we need to understand that the clinical symptomatology is simplified for our understanding into three categories. So category A kind of a illness is a milder kind of illness, which is generally known as uncomplicated influenza, low-grade fever, myalgia, vomiting, headache, and in a healthy child, which is more than 5 years of age and non-geriatric population. So type B category is a little kind of a little severe disease. It is a uncomplicated severe influenza in which there is a high fever, maybe 102 or more, with associated severe respiratory symptoms, may not require hospitalization. But in a special categories like immunocompromised patients, patients with chronic diseases like chronic respiratory disease, diabetes, heart disease, in children who are receiving medications for their immunosuppression like steroids or other immunosuppressant drugs, patients of rheumatological disorders. So these are category B2. And category C is a severe kind of illness, requires hospitalization in which there is a dehydration, confusion, respiratory distress, respiratory failure. So these are basically clinical spectrum of a given patient, but the child or any given patient may start with multiple systemic involvement. So it's not just only the respiratory symptom, but it can present in other ways, like as this is mentioned in this site, like sepsis-like presentation, CNS presentation in the form of encephalopathy, and in a child who is receiving aspirin or has received aspirin by mistake, it can present in the form of acute hepatic encephalopathy, in the form of Ray's syndrome, and other at-risk children like with chronic heart, with congenital heart diseases or rheumatological diseases, especially like Kawasaki disease or other rheumatological diseases, which are already on aspirin, patients of nephrotic syndrome who are on steroids, or other illnesses who are on long-term steroid therapy, or other immunosuppressant or immunomodifiable drugs. So they all have a very severe kind of or a stomic course, and their treatment is of utmost importance. So, in short, the clinical spectrum is varied, but on an average, general presentation is of acute respiratory infection. Over to you, Dr. Ketan.
Thank you, Dr. Ravi. Very nicely elaborated A, B, C category and mild to severe multi-system involvement also. See, this is the summary what Dr. Ravi has rightly described. In children, when you get a respiratory compromise, work of breathing increases, respiratory distress is there, cyanosis is there, some confusion or CNS involvement are there. These are the serious variety of any respiratory disease. In adult also, when you get a persistent vomiting, respiratory distress, difficulty in breathing, even not able to eat, not able to breathe properly. So these are the signs of serious illness. It could be influenza or could be any serious respiratory disease. Dr. Ravi, can you elaborate about diagnostic test? Complication already you have discussed. So we'll focus on the diagnostic test for influenza. Over to you.
Yes. So, there are multiple diagnostic tests available for influenza, but as we had already discussed, mainly the diagnosis is based on symptomatology, because most of the diagnostic tests are very expensive and time consuming. The gold standard test is a viral culture, which is not practical in our situation, which is generally done in reference laboratories only. The common test which we use is a typeable RT-PCR, in which we type different categories of virus like H1, N1, S3, and 2. So these are generally done in a WHO approved laboratories. And there are simple other kind of a PCR also available, which is non-typeable influenza, which can detect type A influenza or type B influenza. Though this is a little inferior test than the standard RT-PCR. Then there is a possibility of doing um, antibody titers. A fourfold rise in antibody titer will tell you about the influenza happening in the particular patient over a period of time. And then uh, there are some places where we have a availability of rapid antigen test also. I think it is not available in Surat. I have not come across this test in our area, but I think that will be a cheap alternative and rapid point of care test. But it is not validated yet. So these are the diagnostic tests we can utilize. But in our day-to-day practice, it is RT-PCR, which remains the gold standard for us. And though it is quite expensive, Dr. Ketan.
Thank you, Dr. Ravi. So to summarize, we can have a RT-PCR test as a high specificity and sensitivity. Rest of the point of care tests are not validated, so should not be used as far as a diagnosis is concerned. If the result is negative, then also it could be influenza disease.
Yes.
Complication already Dr. Ravi has mentioned. Pneumonia, bronchitis, ear infection, worsening of asthma or other respiratory disease, ARDS, and even death can occur with flu-like illness. Management of influenza, let me start it with, if you have a very mild symptomatology like category A, what Dr. Ravi has described, you need a bed rest, fluid consumption should be increased, mild cough suppressant, paracetamol, and in severe cases, NSAID can be used, but especially in pediatric patient, we will not use NSAID as we had seen that aspirin and sometimes other NSAID can cause Ray-like syndrome. So avoid NSAID. Most patients would recover within 3 to 4 days, and severe cases may require adequate hydration, supportive measures, and antiviral therapy. So this is about the antiviral drugs. Dr. Ravi, would you like to take this slide?
Yes. So we have quite good antiviral drugs available for influenza, fortunately, as we did not have that with COVID. So there are two kind of antiviral drugs available for influenza. The commonest one are neuraminidase inhibitors, which blocks the basically neuraminidase enzyme, and which is critical for releasing the viron in the stream. So these drugs are active against both the A and B virus, and two categories are there: oseltamivir and zanamivir. Zanamivir, of course, is for the older children and adult, and oseltamivir used can be used for all age group. And the other kind of a drug are adamantase or M2 ion channel blocker, like in the form of amantadine and rimantadine, which are not very popular drug and not very effective. And as compared to these drugs, oseltamivir, etc., they are little toxic drug. So for practical purpose in day in day out practice, oseltamivir is the drug which we use for influenza in day to day practice. Thank you.
Thank you, Dr. Ravi. So the whole focus would be on the oseltamivir, which is easily available, bit cheaper than all other antiviral, and it is a approved drug for influenza-like illness. Dr. Ravi, already we have discussed, but in Surat, do we get the cases? Can you just enumerate your experience of influenza?
So yes, it was a false kind of a thought that we don't get influenza. Since our knowledge has increased and our awareness has increased, we are finding cases of influenza in our day-to-day practice, ranging from very mild disease to quite severe disease. And there are, of course, seasonal peaks. Like we had a peak in August this year of H1N1, and then in the last month, October, we had a peak of type B influenza. Some of them which required hospitalization, we needed to test them, and we found out these kind of reports like H1N1 or influenza B. So in practice also and in our literature, it is observed that out of 10 respiratory infections, maybe we get one influenza. So this is basically not all the time, but depending on epidemiology and circulating virus, we get these kind of cases. Definitely.
Yes, I do agree with Dr. Ravi. Even in our practice, we had a huge epidemic of H1N1 and other varieties of influenza. In majority of the ICU setup also, when the biofire test has been done, the flu becomes the first number to cause ARDS or severe acute respiratory tract infection. So there is no doubt that flu is existing. So many patients are there, and we need to consider flu as one differential diagnosis. Dr. Ravi, we have a 2-week-old child, history of fever, cough, cold, family history of respiratory infection. What would be your line of action in this patient so far so antibiotic or antiviral is concerned? Over to you.
So looking at the history of this child, this is a child who has a proven fever, cough, coryza, with a proven history of cough and cold, an adult being admitted for ARI. So by look, it suggests a viral illness, and considering the season and spread of the virus, influenza remains the number one possibility. An infant who is 2 weeks is definitely coming under category B. So this child, along with the routine care with saline drop, antipyretic, will definitely like to use oseltamivir in this child because influenza can be very severe in this age group and it can lead to respiratory failure. So I would start with supportive treatment plus oseltamivir therapy as it is a very safe drug.
Dr. Ravi, at 2 weeks, any antiviral, parents are concerned for its safety. So, do you think that oseltamivir is the safe drug at these age? What are its side effects? Over to you.
So, yeah, by literature also and by our own clinical experience, we hardly get any significant side effects of this drug apart from minor symptoms like vomiting or maybe sometime diarrhea. Generally, it is a absolutely safe drug, and we have also used ourselves in our day-to-day practice and has not caused any significant side effect. And the acceptability of drug is also good, and it is available in the syrup form also. So that is the big advantage of this drug.
Thank you, Dr. Ravi. See, it's a very important point for all practitioners. Oseltamivir is very safe drug. Empirical use is justified, recommended by many authorities also. And it is cheaper to use oseltamivir empirically rather than going for the diagnostic test because the PCR test would cost around 4,000 rupees and this drug is bit cheap, costing between 300 to 500 rupees. So it is always justified in a high risk category. Dr. Ravi, the second question to you. 5 years, walk-in patient, mild fever, myalgia, cold cough, healthy child, no family history of ARI. What is your plan of treatment? Would you like to start oseltamivir in this patient?
No, sir, this is a simple ILI case, and we need to just give symptomatic treatment and follow this child up for the worsening of symptoms. Otherwise, straight away, there is no indication of using antiviral drug.
Very nicely elaborated that as in the previous slide, we had seen that influenza-like illness, ILI, with a very mild symptomatology, here we can avoid using oseltamivir or any other antiviral empirically. A 9-year-old child, known case of asthma, fever, cough, running nose, and mild respiratory distress, but not very sick. He's a walk-in patient, and there is a family history of ARI. What is your line of action here? Over to you.
So, yeah, probably in this child, we will be proactive in starting antiviral drug because the child is a sufferer of chronic respiratory illness, and there is a definite history of ARI in the family. So it looks like to be influenza, and especially in the epidemiological region where influenza is prevalent, we would like be proactive and start antiviral drug like oseltamivir with the supportive treatment and with a close follow-up so that his asthma doesn't worsen and he doesn't land up in complication.
Thank you, Dr. Ravi. For the viewers, I think this is a very important message. In a known case of asthma, any viral infection is a trigger. If viral process is removed, but the inflammatory process may continue. So we need to cut short the viral process as early as possible. So here, oseltamivir is very rightly justified even with category A and B symptomatology. Asthma and flu, they are a deadly combination. So flu vaccine is strongly recommended for all asthmatic patients.
Right.
Dr. Ravi, again, a known case of nephrotic on steroid, not vaccinated for flu and pneumococcal, had an acute respiratory infection. Would you like to start oseltamivir here? Over to you.
Yes, sir, definitely. This is a definite candidate to start oseltamivir because there are two conditions itself. Nephrotic syndrome is a immunocompromised state, and the child is also probably on high dose steroid, and the child is also not vaccinated. Even if he would have been vaccinated, it is empirically better to give oseltamivir because these kids can worsen very fast, and definitely oseltamivir with supportive treatment is indicated.
Thank you, Dr. Ravi. So for the viewers, again, this is a category of an immunocompromised child and don't take risk. Start the treatment with oseltamivir as early as possible. Dr. Ravi, 3-year-old child, healthy, came with category A of symptomatology, better, but again the fever reappeared after 5 days, coughing has increased, and X-ray shows bilateral infiltrate and possibly right upper zone consolidation. Can you analyze this case scenario and guide us? What is your line of thought? Over to you.
Thank you. So, this is a previously healthy child without any chronic respiratory ailments or any other chronic diseases. And this child has presented with acute respiratory illness, which is little bit prolonged or basically relapse and remission sort of a thing. So, there are two possibilities here. Either the child has initially started with influenza-like viral illness and then got complicated with secondary bacterial infection. That is the most common possibility. And the secondary bacterial infection has led to the worsening of the child. And sometimes there is a possibility of a worsening or long influenza illness. So there is some kind of immunological or kind of a respiratory involvement which is little prolonged. So these kind of child will require both the therapy, oseltamivir as well as supportive antibiotic therapy along with other supportive treatment. I would definitely use oseltamivir even in the later stages of this illness. But of course, this is a definite indication of antibiotics along with antiviral drug.
Thank you, Dr. Ravi. Dr. Ravi has rightly said that this is a late complication of influenza-like illness. Even if you start late oseltamivir, the benefit of doubt is always there for the patient. It may work, it may stop viral replication, and it may further prevent the progress of the disease. And always think of secondary bacterial and especially staph and streptococcal pneumonia are very common on a damaged lung. And if this patient has been in ICU, the nosocomial pneumonia are also very common because the lungs are fragile, damaged. It is almost like a COVID picture, which we have learned during COVID epidemic. Virus is removed, but the lungs has become fragile, infiltrated, and can cause all complication. 9 years fever, myalgia, mild cough. On day 3, difficulty in walking, calf tenderness. Can you elaborate this case, Dr. Ravi? What is your suggestion and opinion about management? Over to you.
Yeah, so this is basically any sort of a acute viral illness, generally with myalgia, commonly influenza or Coxsackie virus, which present in this way. So it is not probably the primary viral infection which is causing myalgia and maybe little bit of kind of a myositis kind of a picture. And this is indirectly because of immunological reaction to the viral antigen. And it does not require any antiviral drug because it is not a high viral load kind of a condition. It just requires good hydration and supportive treatment. And I think there is no role of antiviral here.
Thank you, Dr. Ravi. So for the viewers, this is an immunological phenomena. We get so good number of cases in monsoon about viral myositis, and this cases does not need antiviral. Something about oseltamivir, it's a potent and selective inhibitor of the neuraminidase enzyme of the influenza A and B. Oseltamivir is a prodrug which is converted to the active form, oseltamivir carboxylate in the liver. It inhibits influenza virus replication and pathogenicity. It prevents further spread of the infection, and it is effective against all strains of influenza A and B, including avian swine flu and H9N2 strains also. This is the mechanism of action. How does it inhibit and how does it prevent? It was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries, FDA, CDC, American Academy of Pediatrics, and even by the Indian government. This slide depicts the dosage. Sometimes it is difficult to remember. Either you can keep it in your mobile or can remember 12 milligram per 1 ml is the strength available in the syrup formulation. Chemoprophylaxis is for 10 days. Therapeutic treatment is for 5 days. For the adult, 75 milligram capsule is available twice a day for 5 days. Below 15 kg, it is 60 milligram per day. So it comes to 2.5 ml BD. 15 to 23, it's 3.75. 23 to 40 kg, it is 5 ml. And more than 40 kg, 6.25 ml BD dose. And for prophylaxis, it is an OD dose. The recommended prophylaxis duration post-exposure prophylaxis, like in a family, there is one patient and there are high-risk category patient in the family, the duration of prophylaxis is 10 days. And if you have a community outbreak, prophylaxis can be taken up to 12 weeks also in immunocompromised and routinely up to 6 weeks. The drug has to be started as early as possible, preferably within 48 hours. Then you may have a better advantage of the medicine. There are benefits of empirical and early use of oseltamivir. It's a wonderful drug, which I'm elaborating by giving you a case scenario. 5-year-old female in the month of October, almost 25th of October, came with complaint of high fever, sore throat, severe coughing, myalgia, body ache. So classically influenza-like respiratory illness. She had a breathlessness, vomiting or diarrhea. Her body was flushed and respiratory findings were positive. Child was admitted on Thursday. Hemogram and CRP were normal. Started on supportive treatment with oseltamivir. This is the X-ray classically showing lung infiltration. Right middle zone, right upper zone, left upper and left lower zone. So this is a classical picture of viral or interstitial pneumonia. On 25th October, X-ray and management was started and patient improved within 3 to 4 days. So early use of oseltamivir will reduce the duration of hospitalization by 59%. Inadvertent use of antibiotic can be reduced and the recovery would be very fast if you start the oseltamivir early. This is what the study has been done and it is showing in this slide. So early use of oseltamivir will reduce the severity of pneumonia. Retrospective medical chart review of 442 patients was conducted and the duration of treatment and the duration of hospital stay was significantly less when you start oseltamivir early. Again, this graph shows that when you start the early treatment, the probability of severe pneumonia reduces significantly and probability of any severity of pneumonia also goes down. So early initiation of oseltamivir is very important. The same things has been highlighted in this graph. The days of hospitalization reduces significantly if you start oseltamivir early. If it has been started within less than 2 days, the recovery or the hospitalization rate is very less. So guidelines and recommendations are from all over the world. WHO has strongly recommended that treatment should be started as soon as possible. Laboratory confirmation may not be necessary for the initiation of treatment. Negative test does not rule out H1N1, and in high risk category, we all should start the treatment as early as possible. And early empirical supportive therapy and monitoring has been recommended by the Indian government, Healthcare Department of India also. And this has been guidelines even on the website also. In adults with community-acquired pneumonia who test positive for influenza, the treatment should include antiviral and associated with antibiotic also in serious patient, because influenza disease predisposes the secondary bacterial infection also. So community-acquired pneumonia, if you have approved data to suggest influenza, only influenza treatment. But if you don't have approved data, then empirical antiviral would be justified. So in summary, proper diagnosis Can an early treatment can prevent flu complication? Empirical use of oseltamivir reduces lower respiratory tract complications, hospitalization, and antibiotic use, and it has been recommended by WHO, American Society, MOHFW, and by all the major authority of the world. So we strongly suggest that empirical use of oseltamivir in category B, C, immunocompromised child, high risk category, adult, and early infancy should be our goal. Thank you so much. Thank you, Dr. Ravi and the team Hetero for giving us this opportunity. Over to you, Dr. Prashant.
Thank you, Dr.
Thank you, Dr.
Ketan.
Ketan.
Thank you, Dr. Ravindra. It was a lovely presentation, especially the classification of influenza and the need of oseltamivir in a particular case. It was lovely. I'm sure the audience must have benefited out of your experience and out of your contribution. Thanks once again. Also thank all the doctors who attended this webinar, who took time from their busy schedule and attended this. Thank you, marketing team Hetero, for conceptualizing this webinar. Thanks, field personnel of Hetero for coordinating. And thank you, IT team Hetero, for all the IT support that you have. It was a pleasure, Dr. Chopra and Dr. Shah, to listening to you for all your inputs. Thanks once again. Wish you a very good afternoon and signing off. Thank you.
Thank you.
Thank
Thank
you.
you,
Bye-bye.
Dr. Ravi.
It was lovely, very nice.